Hello friends, today I'm going to speak on the topic pit and fissure sealants. Some terms for you to remember. Hayat proposed prophylactic odontomy, Bodecker proposed fissure eradication, Bunocore proposed filling of pit and fissure with bonded resin, and Bowen introduced BIS-GMA. Now what is a pit? A pit is a pinpoint depression at the junction of the developmental grooves or the termination of the developmental grooves, whereas a fissure is defined as a deep cleft between the adjoining cusps. Nanko in the year 1960 proposed four principal types of fissures based on their shape, that is the V type, the U type, the I type and the K type. The V and the U type are self-cleansing and caries resistant, whereas the I type and the K type are caries susceptible fissures. So this is the classification of fissures given by Nango in the year 1960, which comprises of U type, V type, I type and the K type. So coming to the classification of pit and fissure sealants, they are classified based on the polymerization method, based on the resin system used, based on whether they are filled or unfilled, and based on the color they are clear or tinted. Based on the polymerization method, they are again classified into self-activated and light-activated. The light-activated is again subclassified into four generations. The first generation that uses UV light, the second generation is self-cured, the third generation uses visible light, the fourth generation uses fluoride releasing. Based on the resin system, they are either BIS-GMA or urethane acrylate based systems. Then there is the filled or the unfilled based on the filler content, and then there's the clear or the tinted. So based on the polymerization system, based on the resin used, based on whether they are filled or unfilled, based on whether they are clear or tinted. That is the classification of pit and fissure sealants. Coming to the indication of pit and fissure sealants. The clinical judgment is the basic criteria whether to use a pit and fissure sealant or not. Other than that, newly erupted primary molars, permanent bicuspids and molars with complete recession of the pericoronal operculatum are indicated for pit and fissure sealants. Newly erupted both primary molars and permanent molars and bicuspids with complete recession of the pericoronal operculum. Then stained pit and fissures with minimal discoloration or opacification can be filled with pit and fissure sealants. Then tooth in question should have erupted less than 4 years ago. So these are the indications for using pit and fissure sealants. So coming to the contraindications, the individual with no previous caries exposure are not ideal. Wide and self-cleansing pit and fissures like the U and the V type are not ideal. Tooth that cannot be isolated properly because they are partially erupted or partially impacted are not ideal. The pit and fissure that have remained caries free for 4 years or above are not ideal. So individuals with no previous caries exposure, or when there is wide and self-cleansable fissures are present, and when the tooth in question cannot be properly isolated or is partially erupted teeth, or the pit and fissure has remained caries free for 4 years or more, are contraindicated for pit and fissure sealants. Coming to the technique of application, first we rinse the pit and fissure with a slurry, then washing and drying is done. Then we etch the tooth surface with 30 to 50% phosphoric acid for 60 seconds. Then we wash and dry the tooth surface. Then the bonding agent is applied, the sealant is cured, and then finally the patient is recalled for review. Coming to the recent advancements in the pit and fissure sealants, there is the ACP releasing pit and fissure sealants, that is the amorphous calcium phosphate releasing pit and fissure sealants. The advantage is that they bind to the hydroxyapatite in the saliva and they result in the supersaturation of saliva with hydroxyapatite and hence facilitating remineralization. That is the advantage of using ACP with the sealant. Then there is the enamel lock TM. The advantage is that it is the first self-etching, light cured and fluoride releasing pit and fissure sealant. So the advantage is that it's a single applicant and it is a tooth colored restorative material. That is enamel lock TM. Then there is the embrace wet bond, which is also a pit and fissure sealant. The advantage is that even if the surface is a little bit moist, it can still bond with efficiency. That is the embrace wet bond. So coming to the previous Yeah, questions. The two questions that were asked are: the pit and fissure sealants are bonded to the surface by, the options were by chemical bond, by adhesion, by mechanical, combination of mechanical and chemical, etc. were there. And the right answer is by micromechanical retention. Because once we etch the two surfaces, microporosities are created on the two surfaces, and this resin tags from the sealant can impregnate into these microporosities, creating micromechanical retention. So that is the answer. And also the second question that was asked is the mechanism of action of pit and fissure sealants. We know that when if caries is to progress, the keys triad need to be fulfilled. That is host, substrate, and time. So by restoring the pit and fissure series with the sealant, we are actually sealing off the substrate from the carious substrate, carious cavity. So without the adequate supply of nutrition to the bacteria, the carious process will arrest. So that is the mechanism of action of the pit and fissure sealants, because they block the nutrient supply to the bacteria. So that is all about this presentation. Thank you.